Yes. Do you think we should do questions after each presentation for a few minutes? Okay.
Do you have, I don't know if you can see like 15 minutes or so. Yeah, I think that's what I'm, yeah.
So let's try to time it.
Yeah, we'll just.
No, no.
And hopefully they're attending on the last day. No. Hopefully.
I think that's the best way.
Like 2 years. Oh my gosh. Like literally don't see them. I probably only gonna be, yeah, and I don't know. My brother's about it. I spent all. I only know the vibes. My vibes. I like the vibe. I only because presenter mode. That's the only reason I know. When you're in presenter mode, there's a clock. That's just start.
Oh, actually, it's just perfect.
So yeah, then I was like, well, we finished having a chat. And I basically thought it was really good show.
All right,
Yeah.
Can I get started?
She is.
Okay. Hi, good morning, everybody. Welcome to Grand Rounds. I'm Nehal Tucker. I'm one of the hospitalists, and I'm lucky to be introducing our 3 speakers today, who are our second-year fellows that I've been lucky to work with these last couple of years. So Dr. Bethany Ferretta is an Arizona native who was born and raised in Flagstaff. She completed her undergraduate training at University of Arizona in Tucson and her medical degree at the University of Arizona in Phoenix, and then pediatric residency here at Phoenix Children's. She further specialized in the care of hospitalized children through the Hospitalist Fellowship program here, and she's completing her training in June of this year. After fellowship, she's joining us in the hospitals division here at Phoenix Children's, and we're lucky to have her. Dr. Emily Mannion completed her residency training at Phoenix Children's as well and continued on for her fellowship here at Phoenix Children's in our pediatric hospital medicine division. Her interests include pediatric nutrition, medical education, and curriculum development. After graduation, she's starting her new faculty position at Vanderbilt University in Nashville, Tennessee this fall. And Dr. Roxana Gugamos is originally from Denver, Colorado, and completed her pediatric residency at Children's Mercy Hospital in Kansas City, Missouri, and then joined us here at Phoenix Children's for her fellowship as well in hospital medicine. Her medical and scholarly interests include advocacy, global health, and migrant and refugee health, as well as DEI. And she's going on to take a faculty position at Denver Children's in Denver, Colorado after her graduation. All right.
We'll just take the microphone.
Okay, hello. Thank you, Nehal. All right, so my name is Emily Mannion. Thanks for you guys coming here today or logging in on Zoom. We did this last year in terms of splitting up this presentation. We're sort of doing some hot topics in pediatric hospital medicine, presenting some of our work that we've done during our fellowship in terms of our research projects. So we will each have a little bit of time to talk and then have a few minutes for questions after that for each one. So again, thanks for being here. And I have no disclosures. My title of my project and presentation today is Characteristics of Infants Hospitalized for Malnutrition and Factors Associated with Readmission. A bit of background first. So children with malnutrition and previously termed failure to thrive can often be managed outpatient by their pediatrician. Some kids, though, will get admitted to the hospital for evaluation for various reasons. And annual hospital costs for these patients are upwards of $6.8 million. Infants specifically are a younger and vulnerable population that have higher rates of malnutrition than their older, compared to older children. Patients can get admitted to the hospital for malnutrition and failure to thrive for a number of reasons, including poor response to outpatient intervention, if there's a concern for an underlying disorder or need for expedited workup, if they have severe malnutrition or acute dehydration, or if there's a need for initiation of tube feeds. Historically, 2 weeks or more admissions were routine for these kids with malnutrition, and now they're a bit shorter stays in the hospital. But you'll often hear providers say to families that they need to stay for about 2 to 3 days of weight gain. But this frequently used recommendation is not based in any current evidence in the literature. And moreover, comprehensive guidelines are lacking to tell us how much weight gain is needed in the hospital prior to discharge for these kids. Overall weight gain goals on both the outpatient and inpatient sides have often been derived from the World Health Organization growth charts you can see here. However, the slopes of these charts, or their weight velocities, demonstrate really just maintenance growth only. Children with malnutrition often need higher goals with catch-up growth that are included in registered dietitian or RD recommendations. Anecdotally, RD goals vary based on individual patient needs, and many use about 2 to 3 times that WHO standard for catch-up growth. This variability will be discussed a little bit later in the study as well. Some recent literature found that the WHO growth charts, when using the WHO growth charts as quote adequate growth, found that 81 to 85% of children under 2 years old admitted for malnutrition met that WHO standard while in the hospital. However, it was unclear from these studies if this observed weight gain would have any impact on outcomes for these patients. A separate large PHYS data study attempted to look at outcomes through readmissions and found that children under 2 years old admitted for malnutrition had about a 14% readmission rate within 3 years. Some risk factors they found were older age, if there were kids with complex chronic conditions, or NG or NJ fees. But due to this being a large administrative data set, they were unable to look at more specific patient factors on a more detailed scale, such as weight gain or feeding modalities. So, taking into account what we knew and what we didn't, we wanted to fill the gap in the literature due to that lack of guidance for weight gain goals while in the hospital. There was an unknown impact on some, more specific readmission or factors that could impact readmission, and wanted to look at those that were able to be obtained through a more manual chart review. And then we wanted to study the most vulnerable population, or those infants under 1 year old. So the objectives for our study were first to describe characteristics of infants under 1 year of age admitted for malnutrition and identify factors associated with readmission. Second objective was to compare association of readmission for these infants meeting daily weight gain based on first the WHO weight velocity standard and 2 registered dietitian goals. For our method, so this was a retrospective chart review study looking at infants 1 to 12 months of age admitted to the hospital medicine service for malnutrition here at Phoenix Children's over a 5-year period. Patients were identified first with ICD codes for failure to thrive or malnutrition, a few of them listed here. And then an individual chart review was performed to determine if malnutrition was in fact the primary reason for admission. Patients with prematurity of less than 36 weeks were excluded, as well as those with a concurrent acute illness. So something like gastroenteritis or bronchiolitis that happened during that hospitalization that may impact their weight trajectory, those children were excluded. Variables were collected via chart review and included those listed here. So things like demographics, those complex chronic conditions, diet details on admission and discharge, different consultations that were placed during the hospitalization, and social factors. And social factors were identified and needed to be stated clearly in either the hospitalist or social work documentation. As for average weight gain in the hospital, this was calculated by taking the admit weight and the discharge weight difference and divided by the length of stay, so reported in grams per day. That grams per day was then categorized as either meeting or not meeting the expected daily weight gain based on the WHO weight velocity standards pulled from those charts from the 50th percentile line for each patient's specific age and sex, and either meeting or not meeting the expected daily weight gain based on the documented registered dietitian goal. The primary outcome for all of the above was if there was a malnutrition specific readmission within 2 years of their primary admission. All right, so 273 infants were included in this study, and 36 of them, or 13.2%, were readmitted. There's a number of characteristics on this slide, which I'll go over, and many did not have an impact on readmission rate, at least statistically, that was statistically significant. So first, sex was pretty evenly split, with 52% of this patient population studied being male, and the mean age of 3.5 months. These two factors were not associated with readmission. For demographics, the categories including race, ethnicity, and primary language spoken are listed below, and each separate category also did not show any impact on or have any higher readmission rates than others. For those complex chronic conditions, there was noted to be 27.5%, or 75 patients that had at least one or more. And when compared to those without any complex chronic conditions, or you can think the quote unquote healthy group, this also did not show any impact or have any higher risk of readmission. For social factors that were identified, again, in the hospitalist or social work documentation, social factors were identified in 63 patients, and a total of 94 individual factors amongst those 63 patients were identified. The presence of at least one or more did not have an impact on readmission either, nor did any DCS involvement that was found in 38 patients. And finally, consultation data was obtained with all 273 infants having a nutrition consult. The next most common being social work with 86% with a consult placed, and speech and feeding therapy with 84%. Each individual consultation on their primary admission did not have an impact for those kids being readmitted later on as well. So with all this kind of negative findings that we found, there was one that showed some statistical significance, and those were patients that had tube feeds on admission. And those patients were associated with a higher readmission rate later on. What's interesting, though, is that this was lost upon discharge. So those patients with tube feeds upon discharge did not necessarily show a statistical significance for being readmitted later. Just wanted to point out here the numbers, which we'll come back to in the discussion, but only 9 patients had tube feeds on admission, 4 of which were readmitted, 5 of which were not. And this number jumped up quite a bit to 88. Not surprising, right, with a lot of these kids getting tube feeds initiated and the reason for hospitalization, but just something to point out that the numbers could have made an impact with this. And then for the secondary objective that we had, we looked at that in-hospital weight gain and sort of categorized it as meeting or not meeting based on who and based on the registered dietitian goals. So overall, pretty close in terms of numbers for kids that met both goals. 78% of patients met expected daily weight gain based on that 50th percentile from the WHO growth charts. And 74% of patients met the registered dietitian goal that was recommended for that specific hospitalization. When comparing the goal to goal or goal to standard, the registered dietitian goal was higher than the WHO standard in 2/3 of cases. When looking at the impact or association with readmission, there was not an association with readmission for infants who met the WHO standard during their index or primary admission. However, patients meeting the registered dietitian goal were less likely to be readmitted later on. And you can see that from the right side of that chart with a p-value of 0.026. So in terms of the readmission rate, it was pretty closely aligned with what was seen in previous literature, 13.2% that we found in our study with a smaller n. For all the characteristics we studied, the one that we found that made the most statistical significance impact on readmission were those infants on tube feeds were more likely to be readmitted later. This could suggest that these infants had a higher complexity than others if they already had tube dependence prior to coming to the hospital. It could also point out to some greater outpatient efforts or challenges in their growth management prior to necessary admission. Most characteristics we found, however, were not associated with readmission. And even we found a lack of association with that complex chronic conditions that other literature showed that there was a higher rate. This could be related to our overall small number of patients or small number of kids that we found with a complex chronic condition that was higher in other studies. We also looked at a younger cohort, so under 1 year old versus under 2 that many other looked at. So there might be some comorbidities or other diagnoses that just have yet to kind of present themselves or might be unrecognized at this age. For weight gain goals, we found that those infants who met the registered dietitian goal were less likely to be readmitted. Those meeting the WHO standard, however, did not have an impact. This could suggest that the WHO growth charts alone are insufficient in assessing appropriate growth for malnourished infants while they're hospitalized. Higher goals with catch-up growth may better support success after discharge. In this study, we also saw that the RD goals were typically higher, but it wasn't true for every single case. During our chart review, there was much variability seen in documentation and often lack in reasoning or some calculations on exactly how each goal was determined. Some limitations included a single center study, so to think of in terms of generalizability. Again, a smaller sample size that we had versus some larger administrative studies. The lack of information on any outpatient success or challenges or things that happened post-discharge. And then I mentioned some of the variability in the registered dietitian data or some missing documentations on determining each goal that was recommended. And then those of us who have taken care of these patients before know that failure to thrive and malnutrition is very multifactorial, and there's probably lots of characteristics or details about these patients that can impact their growth and impact their, again, success or failure or challenges after discharge too. So some further research would include some larger multi-centered studies to confirm these current findings. It would be helpful to incorporate some post-discharge data. Further research would also be helpful to determine standardization of nutrition goals to optimize the outpatient success and reduce or prevent readmissions. The impact that the study has made on an institutional level has been nice to see throughout this project and has led to some increased registered dietitian education that was able to be done just through collaborative efforts with this study and getting some supportive data through the extensive chart review. So a couple quick thank yous. Members of my SOC team are here, and then special thank you to Peggy Fullenkamp-Omens. Again, many of you may know her. She's my go-to dietitian, and she was the one who did some additional education. Again, was able to pull some kind of real life examples from this project and do some additional teaching about catch-up growth and calculations and things with her group too. So thank you to her. And then any questions? We'll just do a few minutes and then move on to Bethany. Yeah.
I think that we often cite anecdotally, sometimes without any evidence, social factors as a reason for keeping a kid in the hospital, concerned that they're going to go home and have to come back in. That was interesting. You didn't list the social factors, but was there a more common social factor that perhaps you hypothesized might lead to readmissions that turned out to not be a significant correlation?
Yeah, that's a great question. So the question was about social factors and what ones we found, or if we looked at if any of those specific ones would lead to readmission. So yes, I know we had a ton of data from this study, and so I did look at that and was able to sort of categorize them. I just didn't include it in this, but it was interesting that it was, I thought, a rather low number of only 63 out of the 273 patients had that. Again, it had to be very clearly documented. So I wonder, either are we not asking those questions? This was also in a time before some of the universal screening for social determinants of health was more consistent or used more universally in our system. So that would be interesting to look at that at that time period once that's more consistent. In terms of most common, educational deficiency was the most common seen. So things like formula mixing, or if it was documented that family didn't know to feed overnight or wasn't sure about normal, kind of frequency of infant feedings, things like that. Next most common was listed for caregiver, either substance abuse or psychiatric illnesses. And then a sprinkling of different kind of like group home and neglect was probably actually lower on the list. But again, I think I'm sure there's
a lot more out there that we just weren't documenting or weren't asking about, or maybe fear of disclosure from family as well. But we did look at each kind of those. They were just such small numbers, so it was tough. But we did look at each category, and there wasn't any significance in terms of if you had this, educational deficiency, that you would be more likely to be readmitted. We didn't find any significance with that.
Then it looks like we had a decent number of patients who didn't meet like either the HOPE-Q or the registered diagnostic goal. I know kind of based on like the way it was set up, it was like discharge rate, admit date. Whereas, do we know how many of those were like patients who like failed all goals and then on like two and again met those goals for like the last 3 days of it, or?
No, that's a good question. So about kind of timing of average weight gain, because we looked at admit and discharge. Where I couldn't find, I also tried to look at, but we couldn't really find a difference either of if would it matter if the last 2 days you met, the goal versus the average, or how many days, consecutive days in a row, because that's kind of what we look at, right? If you were on the positive for the last 3 days of admission and you got discharged, does that matter, or is it really about the average weight gain? There was so much variability, and there were definitely some of those cases where they didn't look great, and then started at 2, but then your average looked okay. So we didn't look at the differences between those kind of kids, which would be interesting. But we tried to look at some of like consecutive weight gain days as well, and couldn't really find a great threshold for saying, 2 days of consecutive weight gain or 3 days of consecutive weight gain would be helpful or not. But
just curious, as you start your next role as an attending, if this is going to impact or change your practice pattern at all.
I think, because what my initial hypothesis from this was that it wasn't going to matter, and kind of no matter what we did in the hospital, it wouldn't necessarily, or the kind of the variability between patients, it wouldn't necessarily change. I think maybe having some higher expectations or expectations going home, and really good kind of discharge planning, I think would be most appropriate for these kids. So I think better improved documentation on how we're getting the goals and what they're meeting while they're here, and then what we would like them to do at home, and then better communication for that, and that discharge with the pediatrician or with the nutrition if they're seeing them outpatient is probably how I'm gonna really change. Okay, thank you.
Good morning. Allow me a moment to pivot to medical education for a moment. If I haven't met you, my name is Roxy Gugamis. I'm another one of us second-year fellows. So thanks for letting me be here today, and a special thank you to all of my collaborators on this project as well. The project, or the title of my project, is Enhancing Pediatric Hospital Medicine Training, Assessing Faculty Needs for Advocacy Curriculum Development. I have no disclosures, unfortunately. Just kidding. But advocacy is the part of the job that I'm sure you guys can appreciate is inherent into the day-to-day and is often embedded within medial tasks that you may or may not have received official training for. This is a problem that has been highlighted not only in hospital medicine, but in several subspecialties, not limited to pediatrics either. We know that advocacy offerings and advocacy activities as it relates to patient care has an influence on health outcomes. And specifically, pediatrics was actually the first residency to incorporate advocacy as a core competency per ACGME requirements. I'm not sure if any of you knew that. As you can imagine, since then, several other specialties have included advocacy or at least allusions to it in their own training offerings, but pediatrics was the first. And pediatric hospital medicine specifically has also included this as well. If you are not familiar with what a milestone is what, I know Anna Gary's laughing over here, but a milestone is what program leadership, regardless of the training program, uses to evaluate their trainees with respect to the core competencies that ACGME has outlined. So just to briefly highlight the anatomy of what the milestone may look like, it looks similar to this. So the core competency is highlighted in that top green banner. We'll see here being systems-based practice. Within a subcategory, they're listing population and community health, and this is specifically the milestone as it pertains to the Pediatric Hospital Medicine Fellowship for Advocacy. Beyond that, the milestones are then evaluated on a 5-point level scale to assess competency in these domains, not to say that you have to achieve a level 5 throughout your training, but this is the metric for which we are evaluated here. So residents and fellows are evaluated by similar metrics. So here we know that the milestones have been in place since implementation of the fellowship. However, they were semi-recently updated, I want to say in 2021 or just a few years ago, with a 2.0 version, and that iteration is the first to have included this milestone specifically in its evaluation. For those of you who are semi-familiar with curriculum development and theory behind this, Kern's model for curriculum development does highlight a stepwise process for which to implement or create a curriculum for a given program. And so there is some data as it pertains to the Pediatric Hospital Medicine Fellowship, and honestly just generalized with regards to advocacy offerings, highlighting that there is a need for dedicated training for this. And there is some work actually underway as we speak for just what kind of offerings the Pediatric Hospital Medicine Fellowship has that is subject to publication hopefully here shortly. But the purpose of my study is to hopefully step into this next step in terms of a targeted needs assessment in compliance with this model. So we know, as I alluded to, that you may or may not have received training in this domain throughout your training. Often this is embedded within patient care and on an individualized basis. And so there is a gap in the literature with regards to structured guidance in this domain. There's typically, as it pertains to not only individual level advocacy, but population level advocacy as well. So this remains poorly defined and variably implemented across differing programs. As you can imagine, the inpatient setting, as it pertains to pediatric hospitalists, highlights structural inequalities and recognizes barriers that our patients are out there. So it provides a unique opportunity to be able to focus on this topic. So at present, no consensus exists on the content of advocacy curricula and the care of hospitalized patients. So the objectives of my study are to do just that. The objective of my study was to examine perceived needs and barriers of program leaders in provision of advocacy curricula for PHM fellows, and as a sub-objective of that, to evaluate the association of program characteristics with perceived needs and barriers in design and implementation of such. The method for my study included an IRB-approved cross-sectional needs assessment survey that was implemented through the U of A REDCap. This survey was designed and curated by several content experts in this field and program leaders across the nation, and it was independently piloted by others, Questions of the survey assessed program demographics, advocacy offerings, at least just at baseline, there is some data coming out already with what general offerings are out there, but just to lay the field, some general advocacy offering questions, and more importantly, the perceptions of their adequacy and the needs and barriers in design and implementation of advocacy specific curricula. For my data analysis, we did summary statistics for multiple choice responses. We did assess program characteristics and barriers cited using Fisher's exact test, and free text responses that highlighted things such as desired guidance that program leaders would like to see or other miscellaneous feedback to have received were included for thematic analysis. This was initially done with independent primary coders and is currently underway with formal coding with independent coders as well through the Deduce qualitative software. So with the results of my study, here just with respect to the respondents, I mentioned we were assessing program leaders, and by that I mean program directors and associate program directors of PHM fellowship programs and not of other specialties. So in total, there are 78 programs in North America, that's including 3 Canadian. 64 or 82% of those programs responded. They did provide the option that we would allow even partial responses, and so the completion rate to that survey was 66.7%. The table is highlighting the regions that are represented who completed the survey, and so we have a general wide response rate from all of the AAP regions, with the least in New York or AAP region 2. However, we do have almost 10% from the Northeast dedicated. Additional demographics regarding the respondents of this survey, including 96% ACGME accredited programs. 93% of these fellowship programs were just 2-year programs as opposed to a 3. 89% had 1 to 2 fellows per year, and the majority of respondents were also the program directors themselves at 87%. I will note that 74% of the respondents in this role are within the first 6 years of that position that they have held. So this figure assesses the survey responses initially prior to asking any specifics about subdomains of advocacy and how they may or may not feel about that, the perception of their program initially. So to give a brief guide to this figure, generally speaking, blue is the strongly agree, purple is the agree, and then red is disagree, and then we have green as neutral, and gray, the strongly disagree, is the smaller hard to see. So sorry if the legend is a little bit difficult to read. But I do want to highlight that initially, this probably comes as no surprise to you, that 89% of respondents cited that prospective trainees describe advocacy as an interest. We know that when you ask program leaders whether they have the staff and faculty to help curate specific training, again, we see 68% responded that they, yes, either agreed or strongly agreed that they did have staff to sufficiently curate this, and that they had the same staff available, or they had at least some staff available to sustain advocacy efforts, even if that particular person left their role. I will note the contradiction here with the top right figure that asks program leaders if they feel like current advocacy offerings adequately prepare fellows to be advocates for children, and that number drops significantly to 41%. So a little bit discrepant from the 89% that cite advocacy as an interest among trainees. In this table, we highlight, or we asked respondents to answer to the perceptions of their curricula. So alluding back to the milestone that was updated just a few years ago, we asked if having this knowledge and understanding of the milestone for fellows as program leadership better equipped you to design or update advocacy curriculum, and the majority at almost 68% said yes. When you asked nuances on whether or not they've prepared specific goals and objectives as it relates to this, that number drops quite a bit at 39.5%. And then specifically with the bulk of the survey, we did get into subdomains of advocacy, general advocacy offerings, and then specifically describing legislative, patient and community, and media advocacy trainings. And so we asked if respondents would benefit from structured guidance to help design or enhance that specific training or model. And just to highlight here, you can see that most programs reported needing additional guidance on the PHM advocacy milestone, which I did not allude to further. The milestone, again, gives you a metric with which to evaluate trainees for, but it does not specifically outline the curriculum or the goals and objectives that you should use. With respect to the barriers cited as it pertains to general offerings and then the subdomains that I have mentioned, we did ask and report the top 3 cited barriers in aggregate for all of these domains. And so this included things such as time, mentorship, faculty staff expertise, interest by trainees, interest by staff. There's a few others listed there below, but what I do want to highlight here is that across the board for all of the advocacy domains that we asked about, that faculty and staff expertise was the topmost cited barrier in all of these. After that, faculty and staff mentorship was the next most cited barrier, with the exception of legislative advocacy, but time was a consistent reporter as well. I do want to highlight that a very small minority of programs cited no barriers in provision of advocacy-focused education, and we did specifically ask if the lack of framework provided by ACGME was a barrier in providing this type of specific focused education, to which there was not an insignificant number across the board that did cite this as a barrier as well, even if it wasn't in the top 3. I will note that there were no statistically significant associations between the barriers that were reported and the region of the program, the duration of the program, and whether or not it was 2 to 3 years, the years of experience of the respondent's role, or the years of the program has already been established. My qualitative analysis remains underway and is currently being hopefully finalized, but to give some preliminary insight, we did ask specifics with regards to, has the new advocacy milestone 2.0 been beneficial, which I alluded to prior. The table below illustrates part of the process for which we did our primary and formal coding, reflecting some themes, but in general, with respect to any subdomain of advocacy, the barriers most cited or the most guidance sought was national collaboration, resource sharing, curriculum development, especially as that pertains to specific goals and objectives. So these preliminary insights tell us that current milestones help tailor the teaching and give a framework with which to provide that focused training so they can better evaluate the trainee, but they do prompt a need for dedicated curriculum and support data-driven improvement. So in conclusion, we know that PHM program leaders across the board support the need for advocacy curriculum and widely report inadequacy in offerings, and that does not pertain to any one region, program, or individual. We know that these programs, as far as we can tell thus far, are saying, hey, we don't need to reinvent the wheel. There's a lot that's being done out there already, and nobody feels like what they're doing is enough and want to collaborate. And I think that there was a hunger expressed for that in terms of the responses that we've gotten so far. The key limitation was a perceived lack of staff expertise, which I think provides a unique focus area for intervention in the future. We know that with national collaboration and some sort of structured guidance, this might appease some of these limitations or barriers felt that are falling on the individual of program leadership. And so I think that that could be a great next step. And we know that governing bodies such as ACGME help shape training opportunities and metrics. And so additional guidance is sought from these governing bodies to help moving forward. So the updated milestone help, but programs are seeking clearer guidance and implementation strategies. So in conclusion, PHM programs would benefit from structured guidance and advocacy curricula design. I will say that actually, it's interesting. I was just at a conference not too long ago where I was touching base with some folks on the outpatient side who says that there's actually work underway to hopefully here in the near future implement some outpatient goals and objectives. And so I think that there's another opportunity for collaboration in the future as it pertains to this. So future directions, I think collaboration, and as it pertains earlier, I alluded to the Kearns model for curriculum development. And with this needs assessment, I think moving forward, we can see to that and potentially move towards a future where we can establish some structured guidance. Limitations of my study, as with any survey-based study, and especially as that pertains to social justice or advocacy initiatives, you have to consider response biases, and specifically as it pertains to social desirability biases, answering in such a way that you think would be more socially desirable. Acquiescence bias is when you are more inclined to agree with something just because it's there and not necessarily specific to the content that it contains. An interpretative bias is when with an ambiguous stem, you might try and analyze that and interpret it in a way that aligns with your own pre-existing beliefs, which is why that we had independent piloters and content experts help curate the design and pilot the design so that we could try and eliminate some of that ambiguity that might be perceived across. I do want to highlight there was a discrepant response and completion rate. And so for that, if there were respondents who stopped answering early on, we excluded them altogether and were not included in formal analysis of the program. For those that had at least substantial contributions to that, we did break down the total number of respondents as it pertains to their data. And then with a survey, you also worry about non-response bias. And usually the concern is that those who are responding may have their own opinions, but not actually represent the opinions of the whole. But I would like to highlight that the inclusion criteria and the focus of this group is largely composed of the similar sample population. So I want to give a special thanks in addition to all of the collaborators on my project with members of my SOC committee. Some of you are here today and I very much appreciate your help. But here are my references and I'll take any questions.
Maybe a little bit of a discrepancy with the response that you felt like you had faculty support even if one person left, and then that was the biggest barrier. Were you able, like not having faculty leadership, were you able to tease out why this different response for those two aspects of the survey?
Great question. So the question was, earlier we had alluded to respondents citing that they had, for the most part, agreed or strongly agreed that they had sufficient staff to help curate or sustain advocacy-focused curriculum. But then one of the largest barriers cited was that of faculty and staff mentorship, and if there was any elucidation as to a possible correlation there versus not. I think that's a great question. I think, initially even just saying, I would say, we didn't get into specifics of why that discrepancy might be there. My hypothesis is that initially those questions were asked before getting into any of the nuances of the subdomains or perhaps even defining them. And so while I think that there are very well-intentioned program leaders out there who support this work, who are pushing to advocate for this work and continue it, especially as it pertains to the interest of their trainees, I think once you get down to the granularity of it and more nuanced descriptions of it, perhaps maybe then, there was some perceived disconnect. I'm not sure, but that's a great question. Any other questions? Great, thank you.
Thanks for your time today. I'm really excited to share our study with you. I'm Bethany Beretta, and we looked at refeeding syndrome, the incidence and characteristics and outcomes in hospitalized pediatric patients with malnutrition. We have no disclosures. Refeeding syndrome is a life-threatening electrolyte imbalance that usually occurs within 5 days of nutritional rehabilitation. In pediatrics, it's been studied in certain populations with severe malnutrition, such as kwashiorkor marasmus, very low birth weight infants, children with eating disorders, or those with prolonged critical illness in the intensive care units. ICD-10 codes do not exist for refeeding syndrome, and diagnostic criteria has really varied until 2020, when the American Society for Parenteral and Enteral Nutrition, ASPEN, made recommendations for diagnosis, anthropometric risk factors, and management of refeeding syndrome. They describe refeeding syndrome as a greater than or equal to 10% decrease in serum potassium, phosphorus, or magnesium within those 5 days of nutritional rehabilitation, but they don't specify baseline values. Their definition also suggests that severe thiamine deficiency or organ dysfunction can also be refeeding syndrome, but thiamine deficiency is not routinely measured here. Outside these studied populations, little is known about the incidence or characteristics of refeeding syndrome in young children hospitalized with malnutrition as defined by these metrics. Additionally, malnutrition is a growing problem in hospitalized children, with rates increasing from 3 to 6% between 2012 and 2019. And the highest rates have been noted in children ages 1 to 12 months, and then again in that 1 to 4 year age groups. ASPEN previously published guidelines back in 2015 defining pediatric protein calorie malnutrition, and one of their metrics was specifically using Z-scores as this definition. And a Z-score is a unitless measure that communicates the distance from the mean, and it's easily calculated from the appropriate growth charts for age and sex, and you can use a single point in time for a child, like their admission, height, and weight, to be able to calculate this value. So the ASPEN 2015 guidelines for malnutrition define Z-scores including mild as -1 to 1.9, moderate -2 to -2.9, and then severe malnutrition would be a -3 or lower. Interestingly, 5 years later, in 2020, ASPEN then proposed these same Z-scores as actual risk factors for developing refeeding syndrome along similar lines. Mild and moderate would require additional factors besides just the Z-score. However, a Z-score of -3 or lower alone would indicate a severe significant risk for developing refeeding syndrome. However, the utility of these Z-scores for surveillance hasn't been specifically verified. Additionally, children with malnutrition in these age ranges may require hospitalization for optimization of their nutrition, even as Emily already presented, but little is known about the incidence or characteristics of refeeding syndrome in young children in this cohort, as defined by the ASPEN 2020 metrics. So therefore, our study objectives were to estimate the incidence of refeeding syndrome in hospitalized children ages 1 to 48 months with malnutrition diagnosed by any means, and then by Z-score severity of severe malnutrition, then compare those characteristics and outcomes of children with and without refeeding syndrome. So we conducted a retrospective chart review here at Phoenix Children's from January 2019 through August 2023. We included children ages 1 to 48 months who were hospitalized for at least 72 hours or more, had malnutrition of any severity by ICD-10 codes, and that would include like mild, moderate, severe, unspecified protein calorie malnutrition, failure to thrive, or weight loss. And then the malnutrition diagnosis was confirmed within 72 hours of admission by both physician and registered dietitian. We excluded any children who did not have a potassium, magnesium, or phosphorus lab values within their first 7 days of hospitalization, those without a height, weight, or therefore Z-score on admission, if the admitting service was other than hospital medicine, if the child was already receiving outpatient electrolyte supplementation or parenteral nutrition, if there was a discrepancy between the dietitian and physician on the diagnosis of malnutrition, or if the child had abnormal electrolyte values and had a confounding diagnosis, such as gastroenteritis, pyloric stenosis, etc. Of note, we excluded children admitted to services other than hospital medicine for a few reasons. Most children with primary malnutrition are admitted to our service and would allow for a more consistent malnutrition diagnosis by a single physician group with our registered dietitians. And additionally, our service does not generally care for children with other confounding diagnoses, such as cancer or acute surgical needs. We collected data from our electronic health record, including age, sex, weight for length Z-scores specifically for children ages 1 to 23 months, and then BMI Z-scores for ages 24 to 48 months, the potassium, magnesium, phosphorus levels, clinical diagnoses, primary admission feeding route, length of stay, readmission within 6 months specifically for the ICD-10 code of malnutrition, and then mortality within 30 days of discharge. We defined refeeding syndrome according to the Aspen 2020 guidelines with a 10% or more decrease in potassium, magnesium, or phosphorus from the lower limit of our reference range here at Phoenix Children's. We chose to use the lower limit because Aspen doesn't specifically specify their baseline values, and additionally, most of our children who met criteria for analysis didn't have lab values obtained prior to caloric initiation. For patients who then met Aspen criteria for refeeding syndrome, the incidence was estimated with a 95% confidence interval, and then we used comparisons to those children without refeeding syndrome using Wilcoxon rank sum, Fisher exact, or chi-squared as appropriate, with a significance evaluated at 0.05. So a total of 1,396 children met inclusion criteria, and among the 849 excluded, the most common reason for exclusion was admission to a service other than hospital medicine, followed by outpatient electrolyte supplementation, diuretics, or TPN use, and then no labs drawn within those first 7 days. After exclusion, a total of 547 children were included for analysis, and 23 of those children had refeeding syndrome. So as I mentioned, of the 547 children meeting criteria for analysis with any degree of malnutrition, 23 met criteria for refeeding syndrome, and that corresponds to an incidence rate of 4.2% with a 95% confidence interval of 2.7 to 6.2. And among children with severe malnutrition as defined by that Z-score of less than or equal to -3, the incidence jumps to 9.33% with a 95% confidence interval of 5.64 to 15. Children with refeeding syndrome were significantly older, as you can see in this table. The median age was 5 months in children without refeeding syndrome, and the median was 16 months in those with. However, there was no significant difference in sex between groups. We found that children with refeeding syndrome had significantly lower BMI and weight for length Z-scores. The median BMI Z-score for children without refeeding syndrome was -2.24 compared to -5.60 in those who did have refeeding syndrome. And for the children ages 1 to 23 months, a similar comparison was found with their Z-score lower as well, -2.02 in those without compared to -3.11 in those with refeeding syndrome. So overall, if we look at that in graphical form using a box plot, you can see that of the group of children who developed refeeding syndrome on the right side of the plot, both the median and the mean, although the mean is not specifically listed, is -3 or lower. And then compared to the mean and median being above -3 in the children who did not develop refeeding syndrome. So significantly more children with refeeding syndrome had the presence of an alternative feeding method on admission. This includes nasogastric, G-tube, et cetera. That was 30.4% of children who did develop refeeding syndrome versus 9.5% of those who did not. Other outcomes, children with refeeding syndrome noted significantly longer median length of stay, and then no readmissions for malnutrition within 6 months of discharge. And there was no mortality in children with refeeding syndrome, although there was one child who passed away in the cohort without refeeding syndrome, but their cause of death was unrelated to malnutrition. We found the incidence of refeeding syndrome in young children hospitalized with malnutrition was 4.2%. And there are actually very few studies to compare this to because few studies have been published using the specific Aspen 2020 guidelines to specifically diagnose refeeding syndrome. One study by Coe in 2020 actually found no incidence of refeeding syndrome in an otherwise healthy group of children who were admitted to failure to thrive. And then since the Aspen guidelines have been published, one study looking at critical care, children in critical care units, found an incidence rate of 7.4%, and they used the Aspen criteria for diagnosis. We found that children with refeeding syndrome presented with low weight for length and BMI Z-scores. Our mean and median for both weight for length and BMI was -3 or below in children who developed refeeding syndrome. This actually validates Aspen's Z-score risk factor for significant risk by itself when a child has a Z-score of -3 or below, and especially combined with the fact that the incidence in the cohort when children have a Z-score of -3 or below, they have severe malnutrition by the prior definitions, and that incidence rate goes up to 9.33%. Our study demonstrates that children with refeeding syndrome were older, and this is actually really different than other studies and other literature that talks about refeeding syndrome. So we hypothesize this finding may be due to the rate of nutritional rehabilitation relative to what younger children have. It could also be related to the duration of malnutrition in older kids. However, further study with metrics that specifically look at duration and rate of caloric advancement by time with the incidence of refeeding syndrome would be really helpful. We found that more children with refeeding syndrome had an alternative feeding method on admission. That was 30% compared to the 9.5%. And we hypothesized that this may reflect that prior feeding difficulties in that child, or there might be some more underlying malabsorptive pathology that has yet to be diagnosed. Could also be related to, again, that rate of nutritional rehabilitation, as a kid who has a tube is going to be more easily fed, and therefore their rate of rehabilitation might be faster, but ultimately further study would be needed to really elucidate that finding. Other characteristics with our children with refeeding syndrome, we found the longer length of stay, which probably reflects the extra time that's needed once refeeding syndrome actually develops for treatment. And we found that children with refeeding syndrome had no readmissions for malnutrition specifically within 6 months, which may reflect that maybe the cause was identified of what was causing the malnutrition. But more study would specifically be needed. And then no mortality, which probably reflects the complexity of really trying to get objective measures to quantify kids who have a total body electrolyte deficiency that puts them at risk for refeeding syndrome versus kids who might just be deficient in calories, but still have that underlying total body electrolyte reserve. So further studies needed to really understand and identify these comprehensive risk factors for refeeding syndrome. Limitations of the study include the innate bias of a retrospective review, as we're really only able to use the diagnostic evidence at the time of the review. And then we excluded children admitted to other services. Therefore, our findings aren't representative of all children hospitalized with malnutrition. And then there was a risk of misclassification bias because we solely used lab criteria to diagnose refeeding syndrome. And we did attempt to mitigate this by a panel review of each clinical scenario with evaluation for potential confounding diagnoses until reaching a consensus to confirm children who actually developed refeeding syndrome. So in conclusion, the incidence of refeeding syndrome in children aged 1 to 48 months hospitalized with any degree of malnutrition was 4.2%. Children who developed refeeding syndrome were older and had lower weight for length and BMI Z-scores and were more likely to have an alternative feeding method on admission. So clinicians should be aware that children with these characteristics are at higher risk for refeeding syndrome and modify their surveillance accordingly. But ultimately, further study with a larger multi-institutional cohort using these Aspen 2020 diagnostic criteria for refeeding syndrome would be helpful to validate incidence and then also do more extensive risk factor exploration. These are my references, and I want to say a big thank you to my scholarly oversight committee that are listed here, all the people that are part of this study. Really appreciate your time. And there's one person in the audience, Dr. Solomon, that we just wanted to shout out from a hospital medicine division that we congratulate him on his retirement. So happy to take any questions. Thank you. Oh, yeah.
If we're looking at the children who are admitted with alternative feeding methods versus oral, how many of the children who were admitted for oral initially actually ended up getting NG tubes during the admission? Like, because sometimes I feel like we'll admit them with failure to thrive. If their Z-score is low enough, we'll just go ahead and drop an NG tube.
Yeah, that's a great question. The question was, how many of the children who got admitted, who were initially oral, then ended up getting a tube? I didn't specifically look at that, and I just looked at the admission feeding route, but that would be a great question to explore for sure.
A comment, I think it was very interesting that the conclusions he got to is kind of what I would have guessed, because for the first half of my career, I mean, a baby admitted for failure to thrive the first 6 months of life, we never checked labs on them other than perhaps on admission, just to make sure they didn't have something weird. And there were never any bad outcomes. I mean, nobody ever died of refeeding syndrome. And last 5 years, I would say the same set of babies that gets admitted for failure to thrive, sometimes I come in there on Q6-hour labs for refeeding syndromes. I mean, so we're checking for this way more often in these little babies. And it was reassuring to hear what you said. It's like, that's not really the population that gets us the most. And I mean, I'm not saying if you have a 1-month-old that's -6 or something, I wouldn't check, I would. But yeah, I think the ones at risk are the ones that you've teased out. It's older patients that have, you know, their body wants to be a lot bigger than it is. They just don't have that nutrition. And all of a sudden you flood them with this nutrition. And, you know, they're building new cells and all those electrolytes are going inside the cells and their serum levels are really dropping. And those are the ones I think that, you know, I mean, refeeding syndrome was found after World War II. And that's when it was discovered. And I think, you know, the concentration camps, and I think those are the type of patients that we need to be looking for, the teenager with anorexia, the, you know, kid that's never had it, you know, family's not giving them the G2, you know, NG or G2 feeds, and all of a sudden you're flooding them with tons of nutrition that they haven't seen in a long time. I found it very interesting, your conclusions.
Yeah, I appreciate that comment. And that's absolutely true. Like finding that who are the kids that we actually need to be doing labs on and who are the ones that not. One of the studies that I mentioned that actually found no incidence in this young age group, they actually looked at how many times labs had to be redrawn because they weren't sure if they were accurate. And they looked at adverse effects of the actual impact on patients. And their conclusion of their study was we are pretty much over surveillancing children. And I looked at our incidents because I was curious to see how much, and we do see it a little bit. And we should look at some of these risk factors because are we poking kids too much in that very young age group who, like you said, might have poor calories, but their actual total body electrolyte base might not actually be as deficient as an older kid who, again, we'd have to do more studies to find out, is it duration or how much to actually deplete total electrolytes. There are a lot of other anthropometric, like arm circumference sizes, but you'd have to do a real prospective study of kids who get admitted for malnutrition and then do all of these objective measures that might better quantify all of this to find out who's actually electrolyte deficient, and then you give them calories and now they become so deficient they develop refeeding syndrome, versus exactly what you said, those who are just deficient in calories but they have enough electrolytes, they're not going to go into refeeding syndrome, they just need the calories back. So great point, and more study is needed. So thank you guys for your time.
It'd be great if everybody can just do our 1-question quiz with that QR code. And secondly, next week we have Memorial Day on Monday, so we don't have grand rounds on a Tuesday when Monday's a holiday. So nobody show up here to the Bowen Center next Tuesday, or you be disappointed by nothing. And you feel like you haven't used your time well. Thank you.